Hello, everybody. I know it's been a long 2 days, so I hope you still have some energy. I'm going to talk to you about the type of research that we're doing, which is a little bit more technical, looking at brain networks and functional connectivity, structural connections in the brain, and the framework that we work with to explain some of the symptoms called the network collapse. I see the date is wrong, it's not December 23rd, but...
I had the same problem,
yeah?
and I corrected it the last day. Because students edit that date. Yeah.
A little bit about myself. I will just show you. I am the scientific director of the MS Center in Amsterdam, and also I have my own research group called Clinical Neuroscience. It's mostly dedicated to MS, but also a little bit of other disorders like psychiatric disorders, because we see some of the same phenomena actually. I'm a neuroscientist. My main passion, I think, if I had to formulate it, we all have a lot of passions, but if I had to choose one today, it would be bridging fundamental science and clinical practice. So that's also why I wanted to give this kind of lecture to you today, since we've been quite clinical, to see how the more fundamental imaging things that we do fit into the story. And I also really like coaching people, so I spend a lot of time doing that. So yeah, this is a little bit about my group. My group is also quite translational. We have people with a medical background, a lot of neuroscientists, but also psychologists, movement scientists, engineers, people who did AI, and some philosophy as well. And we try to integrate all these different insights, also like a bit like a network. So we have a lot of discussions from different points of view, because as you probably also notice yourself, if you have a more technical background, it's still important that you understand the clinical perspective and also how you can integrate this in the stories that you write, because all of us are also, that's what a lot of young people maybe don't realize, but in the end we are writers. We write a lot of stories that are published based on the facts that we find, and the way you write it also matters. Yeah, so we study a lot of mechanisms. So why do some symptoms arise and why do they happen when they do? And how can we measure them? So what kind of outcomes do we have in terms of imaging, apart from the clinical outcomes? And how can we develop new biomarkers that are relevant and perhaps not too difficult to implement? Because I also want to spend more time on implementation in clinical practice. And towards individualized prediction with all these methods. So in the end, we study very complex mechanism with difficult imaging. Can we reduce it down to something more simple, implement it in clinical practice and in clinical trials, and predict who needs what treatment when, but also who is at high risk or low risk, and who is maybe doing quite well. That's also, I think, a new field that we can now move into, who has MS but is doing relatively well, and can we understand why. All right. This is, in Amsterdam we do a lot of imaging research, but we also do a lot of post-mortem research. So we have a program in the Netherlands called the Netherlands Brain Bank. So people who pass away, who donate their body to science, they are registered if they have MS or not, and if they want to participate in MS-specific projects. And the reason why we do this is because we also want to find new insights into the pathology, like what are the immune cells doing, not just in blood, but also in the tissue, and how does that relate to MRI? So can we relate what we see in the tissue to what we see of scans of the same people? If you zoom in, that's one of the things I always show to link pathology to the stuff that we also investigate. If you zoom into this tissue, you see this picture on the left. And do you have any experience with these kinds of pictures? No.
Not much. No.
Okay. So this is a small piece of tissue that has been cut out, and it has been stained for myelin. So you put a chemical onto the tissue, and then if there is a high concentration of myelin, it becomes this kind of brownish orange color. So what do you think is the difference between this? So this is quite a high intense color, and this is less. What do you think this whitish area is? Yeah, exactly. This is gray matter, this is white matter, and this is the outside of the brain. So here you have the white matter, and here you can see an MS lesion. So where normally you would expect that the color would be the same. And that is because the myelin has been attacked and is reduced. I already have a picture. So if we zoom in further, we see this. So this is a magnification. What do you think this is?
Nerve fiber. A nerve fiber?
Nerve fiber? No. These dots are coming outside of it.
They are attacked myelin, the dark spots.
The dark spots are immune cells attacking the myelin. This is a blood vessel. The immune cells are coming from the blood into the brain and then go into the brain tissue and then they attack. Normally you would not see them here because there's no reason for them to massively go out into the tissue. So this blood vessel inside this lesion, that is the central vein sign that Eva showed you a lot before. But you can also find it in the tissue. Now the question is the blood vessel big enough that you can see it on MRI? Because MRI, of course, is based on a resolution of something like 1 by 1 by 1 millimeters, and blood vessels can be really small. Okay, you've seen a lot of MRI scans already, so I can skip this part. But the main point is some people have a high risk of faster progression and other people have quite a benign profile. We call that more benign MS and we want to understand why. So if someone got their diagnosis, that's one of the aims of the research lines that we have. If you only have one scan, can we already profile people into you will probably have a relatively good disease course if you start treatment now. And other people, maybe we have to escalate faster towards more expensive treatments, but then it's something you also want to know as early as possible. And a lot of this is due to the high heterogeneity in MS that you've also seen a lot about already. So on the left, you have someone with not that many lesions, and they're also not so big, but there's a lot of atrophy of the tissue since the ventricles are really large. On the other side, you have someone with not really a lot of atrophy, but a lot of lesions, right? So some people have a really inflammatory profile where other people have a more neurodegenerative profile, and we don't really understand what this difference is. We think part of it is also due to other factors that have nothing to do necessarily with MS, so the sensitivity of the person. The normal heterogeneity between individuals before you get MS could influence the outcome of disorders like MS. That's not specific for MS. There's many disorders, also other neurological disorders, where things like sex, for example, can be quite impactful. What we see in MS is that men tend to have more neurodegeneration than women with the same amount of lesions. So that there might be a sort of protective phenomena in women that we don't really understand. It's been a big part of many research lines in the US where they did a lot of trials on sex hormones, progesterone, estrogen, and so on. They are very successful in animal models of MS at slowing down the severity of the disease. In humans, they don't seem to work. We don't know why. There's these research lines that sometimes there's a breakthrough that can be actually quite simple when you look at groups of people and then you see, oh, there's a very basic difference between the two. So sometimes we, as scientists, overcomplicate things, I think, sometimes. So this is the main part, the clinical radiological paradox. Some people have a lot of lesions but are actually doing fine and also will have a benign disease course throughout, whereas other people don't have a lot of lesions but are not doing so well. And the main distinction between these groups usually is the severity of atrophy. So lesions are very important and they are crucial for diagnosis, but they are not always as powerful at predicting outcomes. Now, you've seen this figure before, just a refresher. This is the figure of PIRA. And you also talked about this one already, right?
I don't recall PIRA.
No? So PIRA, if you remember, PIRA was the slow progression in between relapses or progression when someone doesn't even have a relapse at all. PIRMA, the M stands for MRI. So the same phenomenon also validated that there was no MRI activity in the form of new lesions. So some people have they think it's PIRA, but then they don't have a relapse that they experienced themselves, but there were new lesions. So then we think that still might be driving the progression. But PIRMA is a sort of final confirmation that there was no new immunological activity, but still clinical progression. So the groups are smaller. Of course, more people have PIRA than PIRMA. And also a lot of people don't have this at all. So that's also something we tend to forget, but there's a lot of people that are not progressing and are doing really well on the high efficacy therapies that we have today. This PIRA and PIRMA is something also we call smoldering MS. So something is happening inside the central nervous system that is not driven by new lesions, but something else. Perhaps the worsening of existing lesions that are slowly getting worse, or the severity of atrophy. There's many different theories. This is not the reason why I bring this up at all. It's not isolated to the EDSS, it's also true for cognition, and that's important to know for the rest of the story. So there is also, I think that's in here, yeah. There's also something called cognitive PIRA. So some people don't necessarily worsen on motor functioning, but they do worsen on cognition, or the other way around, or they can have both, or they can have neither. So there's many different patterns of different patients. Yes. Okay. Are you with me so far? Do you have any questions? Yes? Okay. Neurodegeneration in the form of atrophy is a really huge field in MS. In the old days, people would say MS is only a white matter disorder, atrophy doesn't happen, cognition is not an issue, and so on. Now we know that some people have atrophy, so there's been a boom in reanalysis of MRI scans. And thankfully, you can also do this now on clinical scans, so a lot of people are working towards, can we implement this so that the neurologist can actually use this information. This study was quite a special one that I always show, because this is a group of people who don't have MS or another neurological disorder, healthy controls, and they've been followed for 12 years on the same scanner. That doesn't really happen that often, because usually you sell them after a while. I guess also here, right?
Yeah. I mean, 5 time points I count, right?
Yeah.
Wow.
And I also don't know how they did this, because usually controls maybe come twice and then they say, well, goodbye, I have a life. So you see the reason why I show it. This is percentage brain volume change. So the percentage that people lose brain volume, just the whole brain volume over time. And this is normal aging. All of us have this. We all slowly shrink. So the easiest thing is to look at 10 years. There's around 2.5% that you lose in brain volume. This is the same setup, but then people with MS. And what you see is quite a large proportion of people with MS. So they all have lesions, but these are in the normal range. So there's quite a lot of people who have MS who don't develop abnormal atrophy beyond normal aging. But it's important to know that this normal aging happens, otherwise if you only follow patients, then you think there is shrinkage of the tissue and this is a bad thing. But there are also quite unfortunate individuals who have a very severe phenotype, who are very prone to this neurodegeneration. But as you can see, not that common. But this person is maybe one of the worst. In 10 years, they lost 10%. Instead of 2.5%. So it can go both ways. Thankfully, there's a lot of people in this area, but some people are not so lucky, and we don't fully understand yet how much of this we can prevent with treatment. Yeah.
Why does it sometimes go out again?
Yeah, there are a few methodological points that if you drink a lot of water before your measurement, your brain will increase in volume. If you drink a lot of coffee, or there's a lot of these factors, apart from also head positioning, the software that you use, the server that got upgraded, the scanner that got upgraded, that's usually noise. Yeah. No, not really. No, that we know of. Yeah, who knows? Maybe. Could be that they took a new supplement. Would be nice. Yeah. Yes, so we want to explain the heterogeneity in these later stages in the people that we've followed for a long time, but especially early on, can we phenotype people with 1 scan or 2 scans to see if they have a high risk of going in that direction, and then can we then push them back up? And there's a lot of research being done in this topic. So the predictive value for these phenotypes, basically with early changes. So we see that people with a lot of lesions developing in the first years after diagnosis have a higher risk of developing more atrophy, but the effects are not as amazing as we would like. So there are a lot of other factors driving this. Things like sex, but also perhaps other factors that we don't know. I'll go into that a bit more later. So here is an example. Here's one person with MS with different views of the MRI scan. Here's another one. What you can see is there's a big difference if you look at the ventricle size between these people, even though they have the same age, the same type of MS, same amount of white matter lesions, same treatment. But this is a while ago, so the treatments then were not as effective that they are now. And the main difference that we found was actually sex. So in the group of people that we follow over time, male patients were much more sensitive to neurodegeneration than women were. The reason why, we think part of it has to do with how the brain has been laid out. So the structural pathways in the brain, the way they are pruned, that has a lot to do with testosterone and estrogen. So men and women do have different brains, and perhaps men are more sensitive to the impact of white matter pathology than women are. Other disorders are the other way around, so it's difficult. It's also something that's hard to study because you can't really have a good control group or an intervention. You can't really do that without big impact. Okay. One of the regions, if you look at which regions then show the largest effects, the region that shows up all the time in research nowadays in MS is the thalamus. Who can tell me what the thalamus does? Do you know this kind of information? Ah, you're doing, yeah? Yeah?
Integrate the sensory.
Yes. Integrate sensory information and distribute knowledge where it should go and what should do it. Yeah. So it's a bit like Istanbul airport, I guess, in the region. So that's also why I use this in the network story, because if there would be a huge storm here or suddenly a lot of snow and Istanbul airport had to close for a day, this network would not be very happy. So the brain is a bit similar. The thalamus is strongly connected structurally to almost the entire brain. And that's why in MS we think it's such a problem. So we think of MS as a network disorder. Here you can see the thalamus and cortical regions, and the lines are connections between the two. And as MS starts to build up, you see these lesions in red popping up, and wherever there's a lesion, usually some thalamic connection is hit. And because of that, we think the thalamus is shrinking because it's losing connections, or the connections are being harmed. It's a bit like a muscle. If you have injury to your nerves, the muscle will also shrink down because it's losing connections. The same also happens in the brain, we think. Because, interestingly, there's not that many lesions inside the thalamus itself, and lesions in the thalamus don't correlate well with the volume of the thalamus. So it seems to be a sort of second-order phenomena and a sort of barometer, we think, like a thermostat of how the brain is doing. That also has some implications, because should we invest in treatments that are aimed at growing the thalamic tissue back, or should we focus on the white matter? That's a bit of a discussion. And as the disease progresses further, yes, what you then see, cortical areas are also involved, but mostly in people who have a worse phenotype and more in later stages of the disease. So not everybody will have cortical involvement, but quite a lot of people might have some form of thalamic shrinkage. All right. I will skip this part. Yeah, what we see, this is basically what I said before. We did a post-mortem study on the thalamus and also found the damage in the thalamus itself, the immune response and all that, was not correlated with the volume of the thalamus, but it was mostly to do with white matter changes and microglia inside the thalamus. What are microglia? Do you know that?
Brain immune cells?
Yeah, very good. So that's also to do with the smoldering MS story. You have B and T cells that are your regular immune system that come from the rest of your body. Microglia stay in the brain and get activated by this immune system, and they do many different things that we don't really understand. Part of it is they do attack the tissue, but also after we have very successful treatment and the peripheral immune system is then relaxed or shut out of the brain, the microglia are still there. So if they've been super activated by this immune system already before in patients who are really not doing so well, we think maybe that's why some of these people still have PIRA, because the microglia are doing something. So to us it was not that surprising that microglial activation was related to thalamic volume, because maybe they're doing something that is not that beneficial. What microglia also seem to be doing, that's something we don't really understand yet. It is actively, those cells are going around and actively removing connections between neurons. The synapses are being pulled apart by these microglia. Synaptic stripping is what we call it. So again, MS is a network disorder because this kind of phenomena happens as well. So MS is much more complicated. The last 3 years have taught us a lot. But it could be that MS has different stages, and not all people end up in all the stages. So in the beginning it might be a more simple immune disorder. And if you end up in this stage, then it becomes a neurodegenerative disorder, perhaps with different kinds of immune processes that are much more difficult to tackle. So why would it be more difficult to treat microglia than T and B cells with a compound? Yes, blood-brain barrier. Because the blood-brain barrier only allows certain compounds that have a specific size. If the compound is too big, it cannot get in and it cannot touch the microglia because it has to actively touch it. There's new treatments that are coming out that are actively supposed to affect the microglia and this kind of immune system in patients with more severe progressive MS. So that's also quite hopeful that they found a way, and that will open the door to much more research. Okay, is it clear so far? Yes. So what we're also doing is, apart from lesions in the white matter, we're also trying to quantify the damage to these connections, but specifically to the connections, not just in the lesions, because we think MS is a network disorder. So we use diffusion MRI, what I think you are also using, to quantify which regions are connected to each other, and then if you find a connection, how severely damaged is this connection compared to healthy controls. And what we see is that, I'm not sure if there's a figure, that longitudinal changes in these tracts really help to explain why some people decline in their cognition, because the network as a whole is becoming less connected. I'll come back to that later. So thalamic atrophy, I hope I convinced you, is important. We don't know yet if it should be a treatment target in itself, but it is a good monitor to see how the brain is doing. What we also see is thalamic volume seems to be quite constant if you follow the same people over time. So people already have quite a bit of damage in the beginning. They will continue to have thalamic shrinkage over time. But this is not the same for the cortex. If you remember, the cortical involvement seems to come later, and then in patients who develop progressive MS, in some, this accelerates. Cortical volume loss there gets faster as patients progress quicker, while thalamic atrophy stays the same. So again, different stages of the disease, and not all people transition to these more severe phases. Thalamic volume is not specific for cognition or more complex symptoms. It's also related to the severity of motor disability. So here you have a group of healthy volunteers, a group of people with low disability, but MS, and a group with high disability and MS. So what you see is the controls are set at 0. That's a statistical choice. It's not that they have a volume of 0 milliliters. The patients who are not as disabled but still have MS already show some shrinkage of the thalamus. But people with severe disability have a much worse severity of this atrophy. This is a Z-score, so how many standard deviations below controls. So somewhere in between, we think, is a threshold where people start to develop this kind of PIRA phenomenon. So we're trying to find where this threshold is and what a specific warning sign would be for the neurologist and how we can implement this in clinic. So hopefully at some point we can provide you with a form that says this number has been exceeded, maybe we have to do something, or it's fine, you can continue the same treatment as before. This is to show you the cortex, sensory motor network. That's the motor cortex and motor areas in the cortex. That volume stays relatively spared and only becomes involved in people with more severe impairments. So this threshold is not the same for different compartments of the brain. So we cannot just say, just do any brain volume, it will all be the same. There's different stages to different people involving different areas of the brain. So it's a very complex story. And it's interesting for us as scientists, but this is difficult for clinical implementation. Because that means, should we choose cortical volume or should we choose thalamic volume to move towards clinic? We cannot really do everything because then the form would have 20 different variables and then people won't understand.
Can you, do you plan to have like multiple follow-ups to estimate the acceleration of the shrinkage or on the...
Yeah. Ideally, we would use the annual follow-ups for that because I think you need at least 3 time points statistically.
And then maybe you can decide on the treatment that they set on the presentation in the morning, like having the second line option or the first line option.
Yeah.
And then maybe if the acceleration is high, then...
Yeah, exactly. Because one of the problems is also this is a relatively slow process. There's new lesions that can form quite quickly, but this volume change will happen in a year or so after that. So you already are a bit late. Yeah. So it's something we're trying to see if maybe the speed is not the same for different regions that you want the fastest response so you can be quick.
Do you think if you use some kind of fMRI or something to see the network connection, like maybe the volume is getting late, but the...
Yeah, it could be that especially if thalamic volume is the end result of disconnection, that this connectivity measure might be a predictor of there's something going to happen if you don't do something now. I hope so. But that would mean the MRI protocol everywhere would have to include that. And then, especially in peripheral centers who don't do research, how am I going to explain run fMRI and then ask someone from here to process the information? But yeah, at least I hope that we can find something like that that's quicker and more predictive. Yeah. So we also looked at our cohort. Now this is a group of around 200 patients, I believe, who were followed already for a long time. So this baseline measurement is not diagnosis, but 10 to 15 years after diagnosis. And we looked at predictors for cognitive decline after 5 years. So who declines and who doesn't decline, and what is the difference in the first scan between these people. If we look at people who are relatively early in their RRMS, so I think this was before 10 years disease duration, you see that white matter damage is very important. In this case, the connectivity measure, but also thalamic volume. The story that I said before. If you do the same in more severely advanced patients, this changes. So the most important factor that is predicting if someone will decline or not in progressive MS is the cortex. So is there cortical involvement already or not? Doesn't mean that these factors are not important, it's just that this becomes more important. So that's why we think sometimes these are maybe 2 phases of the disease and not the same disease anymore, because you transition, maybe there's a network collapse between these two stages. In the same cohort, what we also looked at, this is one measurement, the first measurement, so you still have the highest sample size. We divided people into groups if they had atrophy in the deep gray matter, so the thalamus, for instance, or in the cortex, or not. And we did that by Z-scores, and if someone had a Z-score of minus 1.5 below healthy controls, we said they had atrophy in that compartment. So this group had no atrophy because they had no cortical atrophy, no deep gray matter atrophy. This is around, of this group, people without atrophy, still around 30% had some issue with their cognition. But if you look at the other groups, so first deep gray matter and then cortex, because we think it moves like that, the group becomes higher and higher, and in this group 75% of people had issues with their cognition, cognitive impairment. So people with especially cortical atrophy have a much worse phenotype. But still, a lot of people already had problems here. So then the question was why, if there's no neurodegeneration yet? Part of it is maybe methodology, because you don't know where they came from, and there's variability in brain size between individuals. For instance, maybe someone had a particularly large amount of gray matter before, which they lost, but they are still in the normal range, so you don't score them as abnormal. That's always the problem with these ranges. Other factors were male sex, so male patients had a faster progression in their cognition, and level of education. Have you heard of education effects before in this context? So people with a high amount of education have a sort of buffer capacity. They can have more pathology with less clinical symptoms. And I'm not talking about focal clinical symptoms like problems in one hand if you have a relapse. I'm talking more about more complex symptoms like cognition. So this is a bit of a tricky one to understand, because you could say this is because they are from higher income families who eat better, exercise, have a better overall health, and have the opportunity to go to university, whereas other people might not have this possibility. Could also be part of genetics, that some people cannot go to university because they don't have the same intellectual capacity, and that influences brain structure, and that is why these patients are more sensitive. Or it could be both. So what we also found, I'll go into that later in more detail, is a lot of this is also explained by the dysfunctionality of their functional network. I'll show you that later, but just as a preview. Okay. Did we discuss cortical lesions in the cortex? Not really, right? I think. So there's a lot of lesions in the white matter that we talked about a lot, which are used for diagnosis. There's also a lot of lesions in the gray matter, especially in the cortex, that are not visible a lot of the times, especially on diagnostic scans like FLAIR. You cannot see these lesions very well. There's other techniques that you can use called double inversion recovery and sophisticated scans that are not routinely done to visualize these lesions, and these lesions are also really important for your cognition. So again, thalamic involvement is important for prediction. Cortex is more about explaining symptoms and people who have a worse phenotype. So thalamic lesions are of course also gray matter lesions, but they're not as important as these. We'll skip this one for now. Okay, so I put this in a bit of a model. If you go from no impairment to very severe impairment, some people stay there, and some people go further down, and it depends a little bit where they stop in their progression. Some people have a really worse phenotype and they end up at the bottom. In the beginning, there might be some thalamic atrophy as a sort of symptom of, yes, there are lesions present and the thalamus feels it a little bit, but it's still fine. And symptoms are remitting. There's not that much going on. As this pathology spreads towards the cortex in terms of lesions, but also in terms of atrophy, mild cognitive impairment starts to begin. This is also what you can see here. This person doesn't have a lot of atrophy. This person is quite severe. I don't know if you've seen this before, but it can become quite bad. But this is not as common. And then what we think, at some point the cortical damage is too severe, and then cortical atrophy accelerates and progression also accelerates in severe cases of progressive MS. So this point is where we think a sort of network collapse happens, where the network is bombarded too severely and the disease transitions to a new type of disorder. Yeah.
So now you say network collapse. Is there a marker to, like, a threshold?
Good question.
To define a biomarker of network collapse. So how will we define a patient is there already?
Yeah. What we think. Well, this is the title of the grant that I'm working on now.
Yeah.
So we have to define it in a way that for science that it explains a lot, and then we can also use it in clinic. What we think is especially the severity of cortical atrophy.
Okay.
If that is, there's a specific threshold in there that then people transition, but perhaps also that there's a first threshold of warning here of the severity of thalamic atrophy. Mm-hmm. In terms of network measures, that's what we're doing a lot of research on, which measure is the most informative, the integration of information or the transition from one side to the other, or there's many things, but so far we haven't found the holy grail yet. So
How about the MRI markers? Like, what kind of markers are you going to use besides diffusion?
yeah, I think for now thalamic atrophy is the most important and also the realistic one to implement in clinic, because mostly because now there are software packages that can do this on clinical scans.
Right.
So that's great. Cortex, conceptually, a cortical volume of the entire cortex would be better, but it's very hard to do. And some clinical scans have very bad contrast in the cortex between white and gray matter. So it's methodologically much more difficult. So in theory, if we can improve clinical images, then volume of all regions of the cortex summarized together, that would be another one. Yeah, but I don't know. Yeah.
So this progression of atrophy, like thalamic and spreading towards the cortex, is it like wherever the lesion is
Yeah, it's a good question, because for the thalamus, yes, because thalamic connections and so on. For the cortex, it's not as random as you would think. So it is not just little pieces everywhere. It seems that these big networks, like the motor system, visual system, that they shrink together. So there is some structure to it that we don't really understand, because I thought maybe it's just this little piece of cortex because there's a lesion connected to it, and then this one and that one and that one. But it seems there's a bit of a buffer. Yeah, and if you look at what happens in the tissue, in the cortex, you see that the atrophy is related to the complexity of the tissue, so how many synapses are still there. So this stripping of the synapses is also something that we think might have a buffer. How many % of your synapses have you lost? And then, so it's a weird thing. Yeah, that's also why cortex is complicated. I like it, that's why.
So, but the diversity of the positions of the lesion
Yeah.
is a factor as well.
Yeah, it is a factor because it does depend on how severely a network has been bombarded. So if you have a lot of lesions connected to the visual system, that will show the most atrophy, or the cerebellum, but the timing when it happens, that is what we don't understand. But a lot of it is, I think, explained by the position of the lesions. Yeah, but as you've seen, that's all over the place. Yeah. Okay. Now I'm moving on to brain function. So do you have questions about structure before we move on? Yeah.
Yes, one question. So the atrophy is generally not the cause, as we see as a consequence. So
Yeah.
the important thing I think is to understand the footsteps of the atrophy and the subtle changes. So do you ever able to analyze the spinal cord of these patients? So we have an observation that also a study that not yet published, but there is something called, and also there are some new studies called like, there's a spinal reserve.
Yeah.
So even you can
Yeah.
tell that patient gonna be progress in the future or not, just looking at the spinal cord as well. And also these structures are shrink together.
Yeah.
So do you think that the answer of, or the cause of the atrophy, or the subtle changes or the footsteps of the atrophy is hidden in the, could be hidden in the spinal cord or normal appearing white matter?
Yeah, it's an important factor because a lot of people have spinal cord atrophy that has never been looked at. Especially now it's getting easier if you have a 3D scan that is a bit lower, you can see it, right? In the cervical cord, you can already identify. So I think a lot of the, especially of course the motor symptoms and the motor PIRA can be explained by spinal cord progression. Why the spinal cord atrophies is difficult to study because the lesions are so difficult to visualize, and if they are in the gray matter or in white matter, but you do see, if you look at the cortical spinal tract anywhere, the severity of bombardment of that tract is related to the severity of the spinal cord atrophy. So I think it's partly the same story as in the brain, but perhaps a bit simpler to study because the spinal cord is one structure that is easily done in clinic, or in the future anyway. So I hope so. And this reserve is something we're also studying. Eva and I have a PhD student who is looking at how you should quantify this reserve. For example, there are studies showing that you could maybe identify how big the spinal canal is, the bony structures, and if that is maybe a concept of how big the spinal cord was once upon a time. And we also look at length. It's a bit more simple to do, which would be great because in clinic that's easier to measure. That tall people maybe have thicker spinal cords in the beginning, so if there's atrophy in those people, then you really think like, ooh. So but it's unclear so far. There's something in it, yes. It's also not clear how they respond to treatment, this marker of atrophy, yeah. Does that answer your question?
Oh yeah, sure. And also
Yeah.
I'm thinking about like the thalamus as a sensory coordination center. Like most of the sensory input comes from the spinal cord. So
Yeah.
the answer could be like before the thalamic atrophy could be hidden in the spinal cord.
Yeah.
We look like mostly patients without a spinal cord lesion, no cervical or thoracic cord lesion. We still see there's a spinal cord atrophy.
Yeah.
And even if it correlates with
Yeah.
optic atrophy and the progression as well. So
Yeah, we also, it's interesting because conceptually you could get atrophy from the bottom up. So if there's a lesion, then there the atrophy will happen, but also maybe from connections down, or both. But even then, I think there's also something we are not visualizing, maybe also to do with microglia, that is also driving the slower progression. Yeah. We also did a study with fMRI on the motor system, and there we saw that the region that was most dysfunctional in patients with more severe disability was actually the primary sensory cortex. So like you said, the information coming up, that disrupts this network, maybe transmits noise, and then the coordination is wrong. Yeah. So there's a lot we're missing at the moment. Yeah. Okay. This is a relatively famous study. It's a bit older, 2011. Because I'm a bit older now already. This was quite big in my PhD time. This is one of the first studies that looked at functional MRI in MS. This is people who don't have a cognitive deficit. The people who with or without MS, all of them are cognitively normal. They were performing I believe it was a processing speed task in the scanner. So you're lying down in the scanner, you're looking at a beamer projecting something that you should be doing. There's a button box that you can use to respond. The performance was also not different between the groups. So here you see the average activation of regions related to performing this task in people who don't have MS. So you see these red areas that are active, and this yellow is the most active region. If you look at the group with MS, you can see the same regions, but there's something different. How would you describe the difference? Spread and increase? Yeah. Those are the two main things. So this region is bigger, and an increase in the severity of activation. So we see that some brain regions are getting pulled in that are not really pulled in if you don't have MS, and also that metabolically these regions are working harder to do the same thing. So that's why a lot of people think this is a sort of beneficial compensation, regions working harder to achieve the same output, because they are not impaired and they're doing the same task. This is what we call functional reorganization. A lot of studies have investigated this phenomenon. So in early stages of MS, where the severity of structural damage, so this is basically white matter lesions, is not that bad yet, there's not a lot of problems in terms of cognition, but also perhaps the severity of motor impairment. People think that this is due to a compensation of the brain for this damage. So that regions are working harder so that despite the lesions that are present, the sort of detours are taken and that the people are still okay. Now again, here you see the same phenomenon as we discussed before, different stages where not all individuals will go to the right. Some people will stay here, thankfully. But in some, there's a threshold where damage becomes too severe. This is, again, the concept of this network collapse, the threshold that we're trying to find, and again, which measure and how that. But you see people with, in stage 3 is what we called it, so severe, more severe cognitive impairment. This hyperactivation is going down and actually goes below. So lower activation than people who don't have MS. So somehow these regions either...
Stopped.
Network is sometimes not big.
Yes. Just don't pause.
Recording in progress.
Okay. There's a few different theories that you could use to explain this. One is maybe metabolic exhaustion of these regions, that they are not able to do this for many, many years. Or that the structural damage has become severe, that atrophy has started to happen, these synapses have been stripped, and that they're not able to do it anymore. But perhaps if you restore the synapses, maybe they could. So there's different theories on what's happening, but at least you see that these patients are not doing so well with all the different markers that you have here. We also see that in this group, the cognitive decline seems to accelerate over time. But again, only in a subgroup of people who are really not doing well, and thankfully with the treatments that we have, we can see that patients are staying more on the left side, which is really good news. Question is, if the treatment does slow down or stop formation of new lesions, but people still have PIRA and start to move to the right again, then what do we do? Well, part of it could be microglial destruction or somehow treating that. Or can we treat this? Should we boost the brain? Should we reactivate this compensation? There are some concerns for this because if a brain region is super hyperactivated for a long time, you also have a buildup of reactive oxygen species, so toxins, that can damage the tissue. So this is sort of use it or lose it versus use it and lose it concepts in neurology. Does that make sense? Yeah. So there's different people doing, for example, electric stimulation of the brain and see if cognition is then stabilized and see what happens. So this is activation. Activation is local metabolism in brain regions that are recruited extra or already present in the activation pattern of the task. Increased metabolism in that region. It doesn't tell you anything about what this region is communicating to the rest of the brain. It's just saying, I am using more oxygen. That's it. Connectivity, functional connectivity, is defined as how does this region communicate to other regions in the brain and what information is being spread. That's a different kind of story that you cannot get from this kind of study. So that's why we also do a lot of resting state fMRI. Because in resting state fMRI, someone is lying in a scanner, you're not giving them specific tasks or instructions, and usually, because of that, you can scan them a bit longer because it's not very invasive, unless they fall asleep. And then you can do these connectivity analyses a bit better. So that's how, in the end, I will show you a bit later what that means. You look at the different communication patterns of the different regions and how much similar patterns of activation they have over time, because at that point they are thought to communicate with each other if they are active and inactive at the same time, because this is all about metabolic activity. So that means at that point it's not about the amplitude anymore, but it's about patterns. Different kind of analysis. Have you heard of these things? Yes? Who can tell me what this is?
This is the active resting state.
Yes. Yes. This is a network. It is, where is it? Very good. This one. These regions are by definition super active if you're closing your eyes and not necessarily your sleep, but at rest. That's why these are called resting state networks. This one is very dominant. It's also why they called it the default mode network, because people thought this is your brain's default mode, the baseline, where you're not doing anything. But this network is doing lots of different things that we find now that are quite specific, so it's not so default anymore. But interestingly, if you are in a resting state, you might be thinking this is all that you're doing, only default mode processing. But actually, and actually maybe you also can relate to this, you're constantly switching between the different networks. So if you are visualizing yourself walking around in the supermarket trying to find milk, you are actively activating a visual and motor network while you are imagining walking. And it's quite an interesting field. People who have locked-in syndrome, so they are in a coma. People who are not actually unconscious, but you cannot tell, they respond to these instructions and they show these networks if you ask them to visualize these things. So there was a really cool study where they distinguished people who actually died in the end and who did not, based on this responsiveness, because they were still there. We all have this, and we study these kinds of transitions between these networks. So I will take you on a bit of a deep dive in these kinds of studies. So what we think is happening during a resting state is you are constantly switching between different processes. And if you are not in your resting state, right now I'm speaking to you, so I'm not in a resting state at all. I'm looking at the outside world, sending stuff there, and you are more in a resting state where you're bringing things in. So your brain is constantly switching between input and prior knowledge. Outside, inside, outside, inside. So we have an outside world and an inside world. This switching is being done by especially the default mode network behavior. So if it is active, you are in an internal state. If it is not that active, you are in an outside state. The default mode network is very crucial for linking memories to what you are experiencing. Constantly checking, like, have I seen this person before? Have I experienced this before? I thought this was not the way it is. And you constantly update your inner self based on the information that you're getting in. Does this make sense? It's a bit science fiction-y, but these studies are really cool. The way we study it now, or we're going to anyway, is by putting people in a scanner and letting them watch a movie. Because in a movie, in a specific scene, you know what kind of information is coming. If it's a thriller or it's something a bit boring and they might go into a resting state and then waking up again, or movement or things like that. And you get a lot of this kind of information, much more than a simple task. So it's quite cool. I think so, anyway. So the default mode network is crucial for this, but also the salience network and the central executive or frontal parietal network. Have you heard of these two before? So the salience network, as you see, it's mostly insula. The insula is what's called island, because it's sort of island inside of the brain. It is a highly understudied structure, but it's crucial for these kind of processes. This network continuously monitors the outside world and the impulses coming in, and decides, should I do something with this, yes or no, yes, no, yes, no, 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 yes, no, constantly. This network then decides, am I going inside, am I going outside? This region is also heavily affected by people with MS with cognitive impairment. There's a lot of lesions inside these areas. This frontal-parietal network is a bit simpler to explain. These are frontal and parietal areas that are crucial for information and processing of cognitive stuff. So working memory, active attention, those kinds of outside-oriented things. So it's a bit of a dance with an anti-correlation between these two based on the salience network. Are you with me? Yes? Yeah.
The salience network connectivity, is it less in people with MS?
Actually, what we see is the salience network is normal in people who don't have cognitive impairment. This whole process then is fine. But patients with cognitive issues shift to the right side, shift to the left side. This becomes hyperactive.
Hyperactive?
Yeah, I also thought it would be going down because of the lesions. But it becomes hyperactive and then this is always on. You don't go back. So you're always internal, you're a bit stuck in your inner world. Quite strange. Yeah. That's the paradox about function. We all think disconnection, lesions, things go down, but actually a lot of function goes up. Higher metabolism, more connectivity.
Maybe trying to deal with processes that are happening in the brain.
Yeah, because we don't know if this hyperactivation is the cause of that, or that it's trying to please go down. You're supposed to shut up. You're supposed to go outside. Come here. You know, could be. Yeah. So, to put this in perspective, this is a map of Holland and the different cities that we have. And these lines are railroads or highways, structural connections between different regions. Some regions are highly connected. Other regions only have one connection. The brain is quite similar to that. So some regions are super hubs like the thalamus, others are not. The red line is someone who lives here and wants to go there. It's a train ride of, I think, 3 hours. Our whole country is not so big. But as you see, this person will not always use the whole network. You don't need everything just for your particular life. In the brain, it's a bit similar, so not the entire network is used all the time for one process. You're switching between different networks that you're applying to the requirements at that point in time. So, what happens in people with cognitive impairment and MS is that there's more severe damage to these highways. It doesn't have to be that they are gone, but it could also be that they are too slow to be efficiently used or less efficient. So this direct path is interrupted. But before people develop more severe impairment, this is circumvented because it's not immediately after you have one lesion that forever you have a really severe dementia or something. That doesn't really happen. So we think this is happening. That people develop a new pathway functionally. So other regions are recruited. That's what we saw before. Other regions are being pulled in and are becoming more severely involved in the same cognitive process. So it's great. But what is the downside to this?
Brain is more active than
Yes. So too much energy overload. Yeah. But there's also something more simple. Think about if you were this person in this network and you had to take this detour. Why do you not like it? Takes too long. Yeah. So this is what you see in these patients with more severe cognitive issues. A lot of them complain about speed. Because it's literally speed in the brain. And myelin also accelerates the speed of processing, of transduction of this information. So this is why, again, MS is a network disorder. That's my motto. Okay, so it's a progressive rerouting of function that is required in order to still do the same thing. That means metabolically regions are being recruited that they were not necessarily required before, and there's a detour. So this network in more progressive patients is not as efficient because it's slower, and is also not as complex because you don't have a lot of choices anymore that you had before. You lose the complexity of this tree. This is a study that we did to study that, to quantify this in a number. This is magnetoencephalography. Have you ever heard of that word? Yes? It's basically EEG, but then with magnetic information instead of electric. But still sensors, you sit under a helmet. All these dots are the different sensors and different regions. And we looked at the most strongly connected regions in this network. And then looked at the shape of that network. And what you see is patients who have a worse cognition have this. So this line-like shape to a network with a loss of complexity and a lot of detours. So we can actually measure this now. It's not just conceptual. So we think as patients develop structural pathology, some thankfully stay here because of a high reserve capacity. More metabolic activity, but also things like female sex, higher education, those kinds of factors as well. And especially those people without cognitive impairments have a preserved functional connectivity, so a normal network, not the detour yet. And if you start to have this detour, deviated functional connectivity, then you have impaired cognition, especially speed.
Do you have a MAC system in Amsterdam?
Yeah, we do. Yeah. Also, we were quite lucky that there was a professor in neurophysiology who was very interested in these things, and he got technology in with a grant from Europe. And we follow these patients, the same patients as the fMRI and the atrophy, also on the same scanner. Yeah. It is great, but it's also such a small field because it's such an expensive machine and nobody has one. Yeah. So that's why we're also considering, can we translate this also to EEG maybe? EEG is everywhere. Yeah. But MEG is much more sensitive. Yeah. Okay. Questions so far? Now I want to go back to fMRI. Oh yeah.
For the cognition, if the system takes more time but achieves the same results,
yeah.
How do you explain that it could affect cognition if it's only on time?
Because a lot of these cognitive tests, for example the speed test, is how many of these things can you do in 90 seconds?
Okay.
If you give them more time, maybe they have the same number, but yeah, a lot of them are timed. It's also, I didn't say that, but a lot of these patients also say that they lost their work because of this problem. So they say, I could do the same things in office behind a computer, but I needed an extra hour and there was no extra hour. So then they lose their job. So that's also why it's important that we also take this kind of information and talk to employers and also physicians in companies to discuss these kinds of things, that the kind of conversations that you should have with someone with MS might also be related to speed, and that there's some things you can do to maybe help them. Yeah. But other tests are, that's why cognitive tests have to be specific for MS, related to speed and related to memory, because an overall dementia screening will show a normal pattern. It will not find a lot of deficits. Like an MMSE, for example, that is used in dementia is not applicable to MS because MS is not a dementia. It doesn't get as bad as a dementia. So that's why, yeah, we have to also teach neuropsychologists about MS. Yeah. Okay. Let's see. This one. We also looked at the thalamus again, but then with fMRI, and looked at connectivity patterns of the thalamus in different patient groups. And here we saw what I also said before, increased connectivity, more communication with the rest of the brain, but only in patients with more severe cognitive impairment. And patients who are cognitively preserved, normal cognition, they have no deviation of connectivity at all. They do have a deviation in their metabolic activity, right? Because the regions are working harder in patients who are doing well, but this then achieves a normal network. That's what we think. And this phenomenon is also, I already showed you, is also relevant for disability. That's what this shows. It's not specific for cognition. This is also something I always show. This method calculates the strength of connectivity of a voxel, so a piece of tissue, with the rest of the brain. If it is orange, can you see this? It is the intensity of increased connectivity compared to people who don't have MS. So you see, people who have normal cognition don't have this increased connectivity at all. And if you move to the right, these regions pop up. Which network is this? Default mode network.
And it is like more active when a person is more severely impaired.
Yeah. So this is an indication that people are more stuck in their inside universe, if you will. If you look at task studies, so we did a study once about working memory. If you look at which regions are hyperactive in these patients during a task, the default mode network is bleeding through. It should be severely deactivated because people are actively doing something, but it is hyperactive even though they are actively paying attention and really working hard. So this is that it's stuck. So this could be another marker of this network collapse. If this is really stuck and you cannot move anymore in your metaphysical inside-outside universe, then it could be a sense of a collapse of the normal network flexibility.
So,
yeah.
Severely cognitive impairment also does mean depression. So that these patients have.
This was a question of the reviewer of the paper. Yeah, so good question. We looked at this, so we also excluded people with depression, and you still see the same thing. And if you look at depression itself, there is some stuff that is perhaps a bit milder, somewhat similar. The default mode network appears in all disorders across humanity, but not specifically this pattern, so that was a good thing. And if you correct for depression also, it remains significant. Yeah, but it could have been, because maybe you're not measuring cognition and you're measuring something else. Yeah, because people who are depressed also don't perform as well on the tests because they don't have the energy to do these stupid... Attention. Yeah, attention is affected in some, but not in all. So if that is a problem, then again, you don't necessarily know if it is an attention problem or really a memory issue. So then it becomes quite complicated.
Did you have a chance to check the insula?
We are doing that now to specifically see how it's dynamically flexing, because after this method was a bit simple. Now we have more tools. I'll show you a bit later how, but that's exactly what we're doing now. So I hope a lot comes out, yeah. Another problem is visual function, because of course a lot of people have lesions in the visual system. If you cannot see what you're doing, your cognitive test is not reliable. So that's also something to screen for. And what we also test now in clinic is you have these tests that are super easy, that even patients with severe dementia should be able to do. And we see that some patients are actually failing that test because they are looking for an answer by the clinician. So this is more a clinical population. If they come to the neurologist and say, I want a cognitive assessment because I think I have cognitive impairment, sometimes they are so focused on it that they want to perform badly. It's a very tricky thing to see what that means. But it's also things you have to screen for. And then if that happens, then the question is, what do? You have to exclude them in your study, of course, but then clinically, then what? Yeah. No, go ahead.
So this default mode network part is on with fMRI.
Yeah.
So because we are I'm doing that. So in fMRI we measure the oxygenation.
Yeah.
So the effect of physiological parameters also is.
That's a good point. Yeah.
So maybe the neurovascular coupling
Yeah.
in that region, not maybe the real neural activity, but the other physiological parameters.
Yeah. So also, especially progressive patients, if they are not able to move around much or exercise, then maybe also their cardiovascular health is not that great, and it could also influence things. But that's why I like resting states, because you don't have a marker that you have to link the coupling to. You're looking at the patterns over time in the same individual.
But in the resting state, so it depends on the correlations.
Yeah.
So if different regions of the brain are also correlated with physiological function,
Yeah.
it can be seen as the correlation.
Yeah, especially what we did see, some things that you should not trust that much is the connectivity with the same region on the other side, because pulsations, that's synchronized.
Controlling for that maybe.
Yeah, but how, it's a tricky one, because if we measure cardiovascular activity during the scan, people get a bit claustrophobic sometimes. That's and also, is that good enough, or at least comorbidities we can check.
We can use EPG.
Yeah. So there are some, but even then, is that you need perfusion in your finger. If the room is cold, then there's always more question. But you're right. That is an important point to improve the measurement, because some people make very, very big conclusions on fMRI that can also mean some other things. So at least that's what I always screen for in papers, if they didn't do this, that they have alternative scenarios in their discussion. Like, we think it's this, but it could also be cardiovascular problems that other studies also really have to look at, that we don't ignore that, like, yeah. This is another interesting thing. There's a cross-sectional data that looks at the different population of patients that you have and tries to rank what seems to occur first. So if most people have white matter damage, for example, then you would rank it a bit earlier, because everybody will have that, and not everybody might have stage 17. This is the staging of these variables transitioning from cognitively preserved towards cognitively impaired. So which is the most early marker of something to do with cognition. Interestingly, white matter damage is number 4, it's not number 1. Number 1 is default mode dysfunction. So it seems that transitioning towards cognitive impairment is especially related to this default mode hyperconnectivity, also in people with not a lot of lesions. And that's what we saw all the way at the beginning in the other picture, that people without atrophy, with not a lot of lesions, can develop cognitive impairment, maybe because they have a more sensitive network. So, but why? That's a big question. And again, insular atrophy is really high. So it's also an important factor that we ignored, really. Okay, so this is what I was saying about the ventral attention system. This is the same cohort again, but then followed over time. So 2 measurements with 5 years in between, and some people progressed in their cognition and others did not. And we looked at this in a different way. So here you have the controls, people who stayed cognitively preserved, those who transitioned to mild forms of cognitive impairment, stayed mild, or transitioned to more severe, or were already quite severe. Sort of a spectrum. But you only have 2 time points, so these are delta scores, changes. So we see that patients who start to transition towards some form of cognitive issues, they have a hyperconnectivity of the ventral attention system. This is before they develop default mode dysfunction, because that is more here at later stages. So it seems there is a staging, but again, like we discussed, I don't know if this is the cause, or maybe it's actively trying to prevent this transition. So it could be that this network is really trying to suppress the default mode network and working harder. But at some point it seems to either give up or get exhausted because it's lost. Yeah.
There's some variability in the data, more variability later than earlier.
Yeah. That's also because these sample sizes are a bit smaller.
Smaller, okay.
Yeah.
That's fine.
Yeah. Yeah.
Yeah. Now I see the answer.
Yeah, so ideally you would do that. But you can't. Yeah, this group is bigger and this group is also bigger.
Okay.
Yeah.
Now I see.
And if you plot the same for the default mode network, it would start around here. And before it would be normal. Yeah. Okay. Now, we talked about this already. Yeah, this is what I wanted to show. It is a movie. I hope it works. Oh, it doesn't work, but it doesn't matter.
Sorry about that.
No problem. But the only thing that you see in the movie is a lot of movement in the images. It's doesn't really matter. This is the behavior over time, so this is what that movie shows you. So this is one person, this is another person. This person has cognitive preservation, but MS. This person has more severe cognitive impairment and MS. This is how we all also seem to behave, because this group was identical to the healthy volunteer group. What you see is there's a high variability in which network is dominant, that's this line, so highly connected to the rest of the brain, and different networks are anti-correlated to each other. This is the default mode network and the visual system. Now that makes sense, to me anyway, because I'm looking at you and actively processing this information, so I'm suppressing my default mode network, because I'm outside. You might be more inside and getting sleepy, so your visual system is suppressed. This also, I anyway, experience this. If you start to get sleepy but you're still looking at something, your vision starts to sort of disappear a little bit, right? You're not as sharp anymore, and that's, I think, to do with this. So normally you transition between this, but also different networks, the motor system and so on, you alternate between them. This is what happens when someone has quite severe cognitive impairment. So how would you describe the behavior in this one compared to that one if this was your paper? Motor? More parallel? Yeah. Yeah. And how would you quantify that? So this is, in this field, there are no numbers that you already have. So you have to think, I think this is perhaps like that. So what would you calculate?
It's the trend over the
Yeah, for example. You draw the line per person and yeah. And you were saying something? Yeah. So they're flatter, but look at the average over time. Is that the same?
These are the average of these maps.
Yeah, so this is the average of the network as a whole and how it behaves. So, but look at the line across the average and see if it's the same in this one and that one.
Did you check the auditory?
Yeah, didn't come out. Yeah, but also the auditory network is a bit biased because you're with earplugs in, and it's unfortunate.
It also like it's also hearing.
It's also input. Yeah. It's really unfortunate that we don't have a quiet MRI, because I think you would maybe see the same. Yeah. It's also why you think, is it reliable to test this in such a noisy machine, because you're being pushed all the time.
Yeah, maybe it's like to.
Yeah. But then. But so the lines are more parallel and the amplitude is not as extreme. If you draw a line at the middle all the time, you end up at like 1. Here, this line is at like -0.5. So they are also lower. There's less variability, but also less in general. For the default mode, the average here is around -1. Here is higher, 0. So this default mode network is constantly hyper-connected, and there's not a lot of going off anymore. It's just always the same. So this is a loss of flexibility that we can now quantify, and that's what I meant with the insula, that we're trying to see if this is the insula failing to...
There was actually an error on the screen. Did you try clicking it? I saw it.
Yeah, it didn't work.
There, yeah, no?
No.
Oh, okay.
The video is not there.
But trust me, it's just colors. It looks cool. Yeah.
Great, yeah.
Is this clear, the concept? So that's the stuff that we're trying to quantify with new kinds of calculations. This network collapse, is that the average going up and down of the default mode network? Yeah.
Just out of interest, is this also somehow correlated with fatigue?
We think that fatigue, well, this didn't come out as fatigue with the default mode, but what we think is correlated is the the composition that we were talking about, that the constant hyperactivation of these areas, that might be driving the fatigue because of the, literally the energy spent. And actually, next slide I think is on energy. It will come. So, we have a structural network and a functional network and different scans in order to study them. And what we see in MS is, of course, the structural network is losing connections, or connections are being damaged, and you have a loss of efficiency. It is becoming less complex, and the functional network is less dynamic, and the default mode network especially is hyperconnected. We think this could be a important marker of why neurodegeneration also, I didn't tell you that, if the cortex becomes involved in terms of atrophy, default mode network. So we think maybe it is a sort of this buildup of toxins in the default mode network that might be accelerating this, in addition to the disconnectivity in structure. But at least these regions are overloaded for so long. There might be something in it. That also might be interesting for the ASL to quantify this. Yeah, we haven't done that yet. So maybe we can do it.
I was thinking maybe same patients might be used for understanding network collapse idea.
Yeah, exactly.
I know it's not working, but I tried to sit far back because I want to train my ear. But I missed out, did you say the central part is overloaded and like trained, or did you say it also degenerates quicker?
I think the functional dominance of the default network is preventing a normal processing of sensory information, to be honest. Yeah. So I think the information is still getting in, but lost because of this constant radio that's always on of default mode, whatever. Yeah, that's what I think. So it's also something we're trying to quantify if it's like a radio that's just outside the normal station and you have a lot of noise and you increase the volume with nonsense, or maybe some other scenario. Yes, so you have structure and you have function. What we're also studying is how structure and function are coupled to each other. Because if you look at the normal brain without MS, there is a sort of pattern that some regions are tightly connected in terms of structure and function. So if there's high connectivity, there's high functional connectivity. That's quite simple. And other regions are perhaps more free to wander around. And how that happens in MS when you lose connections. So what we see is some regions are actually increasing their coupling. This is the dynamic coupling of some networks in patients with cognitive impairment. You see there's an abnormal rigidity in the sense that if there's a high connectivity, there's always a high functional connectivity, whereas in the non-MS brain, this would sometimes not be the case. Structural connections that are super strong sometimes are not used, sometimes they are. But in MS, everything is rerouted to the same subnetwork. That makes sense. Okay, now the energy part. This is a bit more complicated in terms of methodology. If you know the structural backbone of a brain, you know conceptually which connections are stronger than others, but you also know the different resting state networks. These resting state networks, we call them states, so different alternating patterns of functional connectivity that alternate normally. If you know this information, there are methods now with complex models to quantify how difficult it is to switch between these two connectivity patterns, because you have to change which region is highly connected, conceptually. And what we see is, this is more difficult in MS, this switching. Makes sense again, because people are stuck. But that this transitioning, if they do transition, that it conceptually requires more energy to do this. So people still transition a little bit, but it requires more energy. This could also be fatigue, in the sense that it is much more difficult to transition all the time between internal and external states, and that this is a factor driving this. conceptually it sounds great, but we still have to quantify it. Fatigue is a bit annoying to quantify because by definition it is a subjective score. Cognition you can test because you can ask someone, please do this memory test for the next 10 minutes. And then they don't know necessarily how well they're doing, and then you can give it a number. Fatigue is always, how fatigued are you in the morning? How less able are you to do your daily tasks? It's always very subjective. So there's a lot of variability between how people rate themselves. Maybe my fatigue is not the same as your fatigue, and that's normal. So that's a tricky thing. But I think there's something into this, although it's very complex and won't reach clinic. I know that. It's a far away, but it does help, I think, with the story that we portray about how MS works. So, rounding off, the left side we explained already. So, there might be a network collapse, the arrow at the bottom, but perhaps warning signs at the top. People who are doing relatively well might have some thalamic atrophy, symptoms are okay, cognition is not that bad, perhaps some mild impairments, because they have a normal network, because regions are hyperactivated perhaps to compensate and to help. As we go down, there's a decline of this dynamics, the default mode network becomes stuck and getting in the way. And at some point I think there's a network collapse that coincides with the transition towards atrophy of the default mode network. So there could be a direct physical component as well, that the default mode network is too damaged to go back to sleep again. And then you have a rigid and inefficient network. Now the question is, can we push people up again? If you have stimulation of the brain, electrically, magnetically, can we influence the functional network to go back here? I hope so. That's the question.
One more question. So how does it look in demented patients like Alzheimer's, the default mode network?
Yeah, good question. So what we see is all of this is a bit like the MCI stage in dementia. Mm-hmm. And then things get much worse. And there you see at some point in Alzheimer's, it's also interesting that the amyloid buildup is highest in the default mode network. And the connectivity patterns first also go up, the loss of dynamics and all that. And then there's a big collapse with activation and connectivity levels really dropping far below controls. Okay. If so there's severe dementia.
Much less after.
Yeah. So thankfully MS stops here. Okay. That it doesn't get that bad. Yeah, but that's why I think it is interesting and important that we also look at the other fields that we are not in, because in neuro-oncology similar things also happen. In Parkinson's, similar things also happen. So across disorders, you have a different entry point towards the same cascade towards cognitive impairment. That's what I do. Yeah, and then hopefully, if you prevent the pathologies, you don't enter into this system, and maybe this treatment could be the same that you push people back up again. I hope. But again, if you have dementia and your default mode network is really, really severely damaged and destroyed, then maybe this is not case anymore, but in MS I think there's a lot of hope.
I was thinking PIRA, but like this fMRI results correlate to PIRA?
Haven't done that yet. Yeah, we don't know. That's also the next title of the grant that Eva and I were. Yeah, but that's a good question because it could be that you are stabilized because of the treatments, but still sort of slowly going this way, because maybe the neurodegeneration is still progressing or something like that.
As I remember, correctly, so there's nothing going on in the MR, but there's something going on in the body, so the PIRA is occurring and relapse is occurring at the end of in some point. So does something need to be occurring with also the network? So
yeah, the interesting part is also, even without PIRA, relapses are usually, because of the coupling, also what you were saying, during a relapse, this is all over the place because of the leaky blood vessels and all that. So we don't do fMRI during relapses because methodologically it's not really easy, but we miss a lot of information because maybe there's a temporary dip and you go back up again. In terms of PIRA, with internal immune system damage, I think maybe this whole process could still be the same, but driven by worsening lesions, by the microglia taking over from the other immune system, but not developing new lesions, so not a relapse, but still destruction that is.
Maybe the threshold can be more apparent with the PIRA measurement.
Yeah, yeah. So it's always our challenge to quantify a clinical threshold. So when do you think there is a beginning PIRA or something that you might, what we were saying before, that there might be different mechanisms before this cascade and what is happening during the cascade, and yeah, so it's a big slippery slope that you're trying to run on. Yeah. I think this is the final one. This is the whole model of this network collapse. It's a bit of an adapted form of this reorganization figure out before. In early MS, and some people stay here, you have lesions that have developed and clinical impairment is still okay. And network efficiency, that's now this one, is also still okay. Maybe because of this peak in compensation. Sometimes people will then move a bit back and forth here, and hopefully you can stop this with efficient treatment. But some still progress and reach a certain plateau where more severe cognitive impairment will happen because network efficiency, sort of measure, I don't know how to quantify this yet, dips below a threshold. So this threshold and this measure, we're trying to find at the same time.
Yeah, I was also thinking that how we measure the speed, like, so like
Yeah.
optimal way.
Yeah, yeah.
Optimal.
But also means longitudinal measurements are crucial. Yeah, hopefully you can predict the risk factors with one scan, but mapping this requires a high density of follow-ups. And in the end here, this is a zone that you don't really want to be, so hopefully we can push people back to the left. But here the network is showing a lot of cortical atrophy, network efficiency loss, overloaded hubs, rerouting of function that is no longer sufficient to compensate for the damage, and a network collapse and progression. And maybe that's why clinical progression in progressive MS is ongoing without new lesions necessarily forming. So open questions. Why do some people's networks collapse sooner or at all? Some people never collapse. Some people are fine and stay on the left side. Is it really just enough to hit the system quick and early with efficient treatment? That can we stop this whole thing from happening? Don't know yet, because then we have to follow a new cohort with PIRA for 10 years. Tricky. Can we predict it? What happens around the collapse? How do we measure it? Clinically and with imaging. Can we prevent it? Can we boost reserve? And when should we do it? And for how long should we do it? And how do you... Another problem is, for example, we did a study on magnetic stimulation of the cortex. It seemed to work a bit. But if someone has a cortical lesion, you can induce an epileptic seizure. So yeah, so it doesn't work for everybody. And it's not very comfortable, these things. Sometimes, yeah. And what about fatigue? Yeah. Yeah. So what we're going to do after this is, apart from mapping this collapse, can we use this in daily practice? So can we predict, can we make these kinds of curves? If you have a lot of observations of a lot of different people, someone comes in and it's a man, 62 years old, scanned on a Siemens machine. Can you really put them somewhere on this trajectory, and can you predict their profiles? And what I'm also involved in is computational modeling. So if you only have a structural network, there are ways to estimate how efficient the functional network is. We did this before in the study on the bottom right, showing a sort of network collapse that we can simulate. So this might be an answer to these studies where we don't have to wait 10, 15, 20 years and simulate trajectories, and maybe there's already information in that. That's it. Thank you.
Thank you for this wonderful talk, Menno. I would like to ask if you have any questions. Yeah, many. Please, John.
Is there any measurement about the vividness of the visual imagery of the patients?
A measure of the, sorry?
Visual imagery.
Visual imagery, yes, that's a good question. Yeah, it depends. The tricky thing is with these kinds of concepts is you want a task or an instruction to induce specific things. Then you think you have a good measure, and then you scan 50 patients, and then you hope that, yeah. So that's why I drift more towards resting state, because it's not as risky. We had a few times where we did a big study with tasks, and the task wasn't great in the end, and we find nothing. So then you lose 20 minutes of a scan hour. So, yeah. That's why I hope you develop it, if we can apply it.
Not about scanning, but maybe just a questionnaire to see.
That's a good point, yeah. Yeah, and also what's happening in this resting state. That's an interesting one. Also, did you fall asleep? Do you know that you fell asleep? Sometimes people don't know. You hear snoring and they say, no, I didn't sleep. Yeah, good point.
I see with the question.
You mentioned the stimulation with electricity and magnetism.
Yeah.
Is there any different way to stimulate, like chemically maybe?
Also, yeah, you could also give stimulants. We're from Amsterdam, so yeah. But especially in psychiatry, there's a lot of work being done with different kinds of recreational drugs, also to see if that can influence the network and help people. And especially with depression, they're getting quite some cool results. Ketamine, I think. But in MS, we're all quite. Because this group of people, you know, if there are cognitive issues, there's a lot of damage and the tissue is sensitive, so we're a bit scared. Yeah. But maybe it works, we don't know.
So I think maybe some very quick stimulants.
Yeah, there were some studies on acetylcholine stimulants, for example, but relatively low dosing because people were a bit afraid.
It's also tricky, I guess.
Yeah. Because you cannot do a normal dose response curve in patients. It's tricky. Yeah, but it could be something in there that we don't know. Yeah.
Maybe placebo.
Yeah. Start with that.
Any other questions, Holland? Yeah. Esra?
Thank you for your great talk. So I'm not familiar with the brain networks, but is there any measurement for network complexity for these patients?
Yeah.
An optimum measurement, or there are several?
Good question, because just like thalamic volume, you also want to know what is normal. And for complexity also, we want to get a taste of, if you only have one scan of one person, you want to know how abnormal it is. So that's what a lot of cohorts are being used for, to describe the normal architecture of the brain and which measure is good to explain it. I think there's one interesting one where you look at only strong connections and the shape and the complexity of it. You can give it a number. But then you only look at the strong connections, and maybe all the information is in the weak connections. That's what we don't know.
Depends on the patient, right?
Yeah, and maybe in MS it's the strong connections, but in Parkinson's it's in the weak connections. No idea. So, but do it.
Yeah,
So about the MEG parts, you look for different bands.
Yeah.
Maybe frequency like in the correlation, it is more like a time dependent.
Yeah.
Maybe in the frequencies.
Yeah, it's an interesting one. Eva also did a lot of work on this and published a paper on the peak frequency. So normally it has a specific frequency where most of the activation in the brain, at what frequency it's happening. And you see it's getting slower in people with cognitive impairments. And if you don't have cognitive impairment, it's relatively normal. And then if we separate the bands and analyze their networks, you also see different things happening in different bands. So we thought, before also what you said about the downsides of fMRI, that MEG would solve everything. We thought that, but it gave us many more questions and no answers. So if one band goes up, the other goes down, and the other stays the same. And so, I think there's a lot of information in it that we're not grasping fully yet, because we need a more advanced model. So that's what other people in our department are now developing, the interaction between the bands in the same people and how they are connected to the structural network. So it's cool, but goes over my head at some time. Yeah, but good point.
Yeah, a lot of interest. Definitely.
Thankfully.
Thank you for this nice talk.
Thank you, thank you.
I would like to give you the speaker recognition.
Great, thank you.
Wonderful.
Thank you.
Thank you.